Hello, everyone. In this session, we will be discussing advanced stage cutaneous lymphomas. And before we get started, I would like to thank our corporate partners and individual donors. Thank you so much for making these programs possible. Our wonderful speaker for this discussion will be Dr. Jennifer DeSimone. Hi, Dr. DeSimone. Thank you so much for joining us.
Hi, I'm happy to be here.
Dr. DeSimone is an assistant professor at Georgetown University Hospital Department of Dermatology. She is also an assistant professor at Virginia Commonwealth University School of Medicine and the director of cutaneous lymphoma and high-risk transplant dermatology at Inova Schar Cancer Institute Melanoma and Skin Oncology Center. So I'm going to go ahead and turn things over to you, Dr. DeSimone.
Okay, thank you again. I'll just jump right in here. I have a couple disclosures, none of which present relevant conflicts for our talk today. So here's my plan for the day. I want to briefly define what advanced cutaneous T-cell lymphoma is. We'll have a brief review of the etiology or theories for why people get this disease. And then most of the talk will focus on treatment options. So I'll talk about the mechanisms of action of basic therapies that we use, the track record of those therapies, and then try to give some insight as to why your provider may choose one therapy over another in your treatment plan. So advanced cutaneous T-cell lymphoma basically refers to stages 2B through 4B. It includes Sézary syndrome, large cell transformed MF in advanced stages, and in many cases includes aggressive subtypes of mycosis fungoides. So here we're just talking about, again, the more advanced stages beyond 2A. We're also including some of the aggressive subtypes, specifically gamma delta T-cell lymphoma and cutaneous aggressive CD8 positive epidermotropic T-cell lymphoma. However, the more classic mycosis fungoides subtype is probably the most commonly encountered disease, even in advanced cases. And that again just refers to the stage at which patients present. So where does this problem come from? We are not entirely sure. We do know that there seems to be some association, although it's not a direct cause and effect relationship, among a hydrochlorothiazide, an antihypertensive agent, selective serotonin reuptake inhibitors, and certain anticonvulsant drugs. Many theories have been advanced trying to link CTCL to certain viral infection, but none of that has been very conclusive. Additionally, there's no genetic mutation that someone can inherit that leads to this cancer the way that we observe in other types of cancer, and there's no consistent chromosomal abnormalities that have been identified. So the leading theory is that patients are exposed to some sort of chronic stimulation in their immune system, specifically in the skin, that kind of overtaxes the system and leads to an error occurring. And we know that Staphylococcus tends to be one that's really on our radar, specifically when we're talking about mycosis fungoides. So I like this particular schematic drawing because it just kind of gives you an idea of all of the different things that are in play when we talk about what stimulates the emergence of a T-cell clone. So in the normal physiologic state, there are T cells, parts of our immune system that exist in our skin, and their job is to sort of run surveillance for a bacteria or a virus to try to gain entry into the skin, and then they respond in a very specific way to try and clear that infection. Sometimes that entire process just gets overtaxed by exposure to a number of different things, both inside and out, that can lead to an error being made and to a development of a clone or a group of those T cells that are genetically abnormal. So here we're going to talk, I just want to demonstrate the concept of epigenetic mechanisms. And what that means is that there's some interplay between your genetic makeup and the environment around you, and basically some sort of critical threshold that you surpass that can lead you to develop this particular problem. And those exposures to the outside world can happen in utero as a developing fetus, early in childhood. It can include exposure to environmental chemicals, long-term ingestion of certain drugs, the aging process, and food products that we consume. So a few brief clinical examples of the various stages. These are two patients who have tumor stage disease. This is a patient who is erythrodermic with widespread body surface area involvement. And this is kind of the classic combination representing Sézary syndrome, which includes erythroderma, meaning bright red head to toe, big bulky changes in your lymph nodes, and then lots of disease on your blood smear. Here are two examples of patients with large cell transformed disease as well. So one common and really important question that I get from patients, whether they're presenting with early stage disease or kind of middle of the road disease, is what is my risk of this progressing to truly advanced disease? And the best study to refer to looked at almost 1,300 patients and followed them for over 25 years. And basically what they found was that the progression to more advanced stage disease occurred in just under 10% of patients. So that's the number that I typically counsel people to focus on. The odds are pretty good for a stage 1A patient who comes in. They're going to have a 90% chance of really never progressing to advanced disease. But the more far along you are at your initial presentation in terms of how much disease is on your skin directly correlates with an increased risk for developing advanced disease down the road. And it's also important to note in this discussion, even though we're focusing on advanced disease, that patients who have stage 1A really fare very well, and their overall life expectancy is similar to people of their same age and gender who do not have CTCL. Another important thing to just touch on quickly is the scenario where patients develop large cell transformation. And the term CD30 positive large cell transformation specifically refers to a histopathologic or an under the microscope diagnosis where more than 1/4 of the abnormal T lymphocytes are double their expected size, and more than 1/4 of those cells also display a specific protein marker called CD30. So large cell transformed disease can present usually in one of three patterns. It can be in a patient who has classic mycosis fungoides, and now they have a new big nodule. So different from their flatter disease, now they've got something dome-shaped and raised. It can occur in a patient who doesn't have a prior diagnosis of mycosis fungoides, but who develops multiple scattered little bumps or bigger nodules. Or it can occur, and I think this is the most common pattern, in a patient who has pretty advanced disease with thick plaques or tumors already, and now they've just got a little bit of a what we call morphologic shift or a change in how big or how protruding those tumors look. And that's what I encounter most commonly. So the risk of developing large cell transformation is also directly proportional to your stage at presentation. So for stage 1 patients, they have virtually no risk, less than 2%. But as you start to get up to the higher stages, specifically stage 4, it can be almost half of patients that will go on to develop CD30 positive large cell transformation. Why is this important? Because it does seem to be linked with a worse prognosis in some instances. Here's a graph just showing patients who, yes, do have large cell transformation versus no, do not have transformation, and their survival. And you can see that those who did have large cell transformation did not have as good of outcomes as those who did not. All right, now we'll transition into kind of the main focus of the talk, which is the various forms of treatment that we can offer patients. I like this particular drawing because it up top just takes you from early stage disease 1A, and then as you move to the right over to the most advanced stages of disease. And then it shows you where the various therapies fit. So you can see early on, we tend to focus on what we call skin-directed therapies. Those are things that you're putting just on the skin. You're not ingesting anything, nothing's going through an IV. You can see that radiation therapy can really be used across many different stages of disease. But then when we start to look at more advanced stage disease, we heavily rely on systemic therapies, maybe photopheresis, or even enrollment in clinical trials. I want to briefly introduce the concept of compartments. So when you're thinking about cutaneous T-cell lymphoma, one very important distinction is to determine where in the body does any individual have disease. And it can occur in one of three places: in the skin, in the lymph nodes, or in the blood. And there can be overlap or involvement of multiple compartments. But when we select therapies, we have to choose therapies that have a good track record in achieving success or clearance in the compartment that matches the disease presentation of the patient. All right, so starting with skin-directed therapy. As the schematics show, this is most appropriate for early stage disease, but it can be used in combination with other systemic therapies in patients who have advanced disease. And skin-directed therapies typically include things that you apply topically, the use of phototherapy or light-based therapy, and radiation. So starting with topical agents, topical steroids are very commonly used at some point in the treatment of cutaneous T-cell lymphoma. And they should have effects that are beyond just reducing itching or reducing redness. Theoretically, they should be able to interrupt the stimulation of the abnormal lymphocytes, and they should be able to promote something called apoptosis, which is programmed cell death of an abnormal cell. And that's very effective in eliminating some of the abnormal T-cells that may be present. Topical nitrogen mustard or mechlorethamine is another topical agent that we use with some frequency, usually as an add-on for advanced stage disease in combination with a systemic therapy. This is something that causes targeted death of the malignant T cells in the skin, and it can have efficacy not only in patches, but also plaques and even tumors. It's typically applied once daily at night, and it can be used either from the neck down to just kind of try to knock out everything, or broadly on individual lesions. And that's more of a stylistic point on the part of your provider. Some patients do develop a very significant allergic reaction or an intolerance to this medication. That can happen in up to 20% of people. Toll-like receptor agonists. Some of you may have heard of this. The main one that we are able to get our hands on commercially is called imiquimod. And this is basically a skin-based immune boosting agent. And so what it does is it increases all of your naturally occurring, what we call chemokines, or basically functional chemicals or proteins in your skin that enhance your anti-tumor response. So this isn't something that's directly killing the abnormal T cells like mechlorethamine, but rather it enhances any given patient's natural immune function against the T lymphocytes. So it takes longer to kick in. We don't have really large scale studies to be able to quote efficacy percentages, but in the patients in whom it is effective, you have the potential benefit of having kind of long-term clearance and control of disease. And in the very few studies that we do have, I'll mention briefly one of them, a patient who achieved a complete response was still clear at 8 years. So that's what I'm getting at, is that it seems to kind of educate your immune system to stand up and fight against these malignant T lymphocytes, and that tends to be a long-term benefit. Phototherapy or light-based therapy. This is thought to work via two mechanisms. One, direct killing of the abnormal lymphocytes on the part of the ultraviolet, but then also a local immunosuppressive effect. So what that means is that you may have the presence of abnormal T cells in your skin. That prompts an immune response from the surrounding healthy immune cells that manifests with more redness, more itching, more flaking. And the ultraviolet light tends to really mitigate that component of the whole picture. So while you might get less direct actual killing of the abnormal cells, you definitely reduce the healthy immune response that drives a lot of the symptoms. We administer phototherapy as either ultraviolet type B or ultraviolet type A, and it's something that can be combined with systemic therapies. So briefly, narrowband UVB, it's kind of like a medical grade tanning salon. There's just one specific wavelength of light, 311 nanometers, that is administered, and that is the one that helps the most with reducing inflammation. Typically, patients are started 3 times a week, and you have to slowly increase the amount of time that you're in the box as tolerated so that we don't burn anybody. PUVA, this is UVA, so a different wavelength of light, combined with something called psoralen, the silent P, hence the name PUVA. And psoralen is a photosensitizing agent. So basically, it works its way into the abnormal lymphocytes and makes them much more sensitive to killing by the ultraviolet type A wavelengths of light. This is something that's combined often with things like photophoresis, interferon, oral retinoids, etc., for advanced disease where we need a combination approach. Radiation oncology. So this can be used either in a focal way, which means that we use typically electron beam type radiation to treat specific lesions, or we can do something called total skin electron beam radiation, where we're trying to evenly reach the entire skin surface. Here's an example of a patient who underwent total skin electron beam, and you can see that there's pretty dramatic clearance of the skin lesions there. The problem is that the amount of clearance that you get is pretty consistent across many stages of disease, including advanced disease, but the duration of that response dramatically goes down if you present with more advanced disease. So what I'm talking about here is that this one study showed the progression-free survival times for various patients. And in the patients who presented with stage 1B, they had no disease for over 2 years. But in the patients who presented with stage 3, they had improvement that was durable for less than a year. So you have to use total skin electron beam in combination with other therapies, or at least with an immediate introduction of another maintenance therapy. Okay, retinoids. So these are medications that are kind of in the same category as Accutane. They're called vitamin A analogs, and they've been used for over 3 decades in the treatment of cutaneous lymphoma. What they basically do is encourage that apoptotic phenomenon that I mentioned earlier, where you have a programmed and targeted cell death of abnormal cells. And so that's how they assert their benefits in this setting. They work inside the nucleus of cells. So the main one that we use in cutaneous T-cell lymphoma is called bexarotene, or oral targretin. And this is a synthetic form of a retinoid. It was approved in 1999 for refractory or advanced stage CTCL, but it's also been shown to be effective in early stage disease. It acts in a number of specific ways that I won't get into here, but basically the end result is a programmed death or an interruption of the proliferation of the abnormal T cells. It can be used alone. We call that monotherapy or single agent, or in combination with other medications in advanced stage disease. Typically, we start patients on 300 milligrams per day. That's called the loading dose. There are side effects that are consistently encountered in anybody on bexarotene. And these aren't things that people really feel, so it's not necessarily fatigue or hair loss or anything like that, but they're lab-based side effects. So one thing it's going to do is interrupt the signals to your thyroid to produce thyroid hormone, and it can elevate your triglycerides or your cholesterol. So we automatically have to start people on thyroid replacement and lipid-managing drugs or cholesterol-managing drugs when they start bexarotene. Here is a look at 3 studies just looking at kind of how many patients responded to bexarotene, and you can see that there's a wide range of, we call it overall response rates that are reported here, ranging from 24% up to 100%. Here's an example of 2 patients with very good responses to oral bexarotene, a Sézary patient here on the left, who was then stable on a maintenance dose of just 1 pill per day, and then a stage 2A patient after only 6 months of bexarotene. This is a patient of mine who had florid Sézary, and you can see that in less than 4 full months, he had a dramatic response to just a loading dose of single agent bexarotene. Okay, now we'll move into systemic drugs called antimetabolites. And I'll kind of gloss over these because some of this stuff is very detailed and probably not all that relevant to a patient-based forum. But the first one that I'll discuss today is doxorubicin. And this is something that gets into the DNA and binds to it and basically causes the DNA double helix to break open and therefore kills the abnormal cells. It's given through an IV every 2 or 3 weeks, and the overall response rates in advanced stage MF and Sézary have been reported to be as high as 88%. The main problem with doxorubicin in terms of side effects is that after you've been exposed to a certain total amount of the drug over time, it can have a very deleterious effect on how well your heart as a muscle can pump. So it can affect the individual cardiac myocytes. So we have to watch the cumulative dose that patients get. In our hands, it's been very effective in reducing bulky tumor stage disease. So this is a patient of ours who had big tumors. He'd had radiation already. There was a recurrent tumor kind of right next to the field. And after just 4 infusions of Doxil, it was completely diminished. This particular gentleman had other tumors elsewhere that responded after 1 dose. So it can be very effective in certain patients. Another drug in this category is called gemcitabine or Gemzar, and this is given through an IV on days 1, 8, and 15 out of every month. The overall response rate in advanced stage CTCL patients who've already tried and failed a bunch of other drugs was 68%, which is pretty good. And this is also a drug that is useful in debulking large tumors or big nodules in patients. The next drug in this category is called pralatrexate. This is a cousin to methotrexate, but it's given through an IV. And again, it kind of interrupts the cellular proliferation of the abnormal T lymphocytes. and the overall response rates are about 27% reported in advanced CTCL patients. The main side effects to look out for are kind of collateral damage of targeting rapidly proliferating cells, which is what we see in cancer. You can also have some interruption of the cellular proliferation in rapidly cycling healthy cells, like the cells in your oral mucosa and in your mouth. And so patients can have really painful, burdensome lesions that develop in their mouth that may be a barrier to being able to take this therapy. Here's a patient of mine from fellowship who had pretty widespread disease, and she cleared nicely. Okay, now the next big category of systemic drugs I want to cover are called the targeted therapies. And what that means is that we're kind of honing in on specific protein markers on cells and trying to attack them in a targeted fashion, or in the case of HDAC inhibitors, specific enzymes. So starting with the HDAC inhibitors, or histone deacetylase inhibitors, this is a big group of drugs that has a multitude of effects that, again, all kind of result in reducing the proliferation of the abnormal T lymphocytes. And we know clinically that these drugs have provided great reduction in the horrible itching that can accompany cutaneous T-cell lymphoma. Vorinostat is the oral form of drugs in this category, with response rates ranging from 24 to 30%. And then romidepsin is the intravenous form of this medication, with response rates a bit higher, 31 to 34%. And this is given as an infusion on days 1, 8, and 21 of a 1-month cycle. This particular medication does carry some major side effects. First of all, the infusion lasts about 4 hours, so that's a big consideration when choosing a therapy. And also, many patients will have fatigue, nausea, and loss of their sense of taste for 48 to 72 hours. So it's a tough drug to take, but it does have its role in the treatment of patients with advanced CTCL. It can also be used as a maintenance therapy. So we can dose it in the way that I described until patients get good clearance of disease. And then we've had success dosing patients just once a month or once every 2 months. And we've had good maintenance of that benefit with romidepsin using that dosing regimen as well. The next category is called monoclonal antibodies. Monoclonal antibodies are drugs that will work their way right into a specific protein marker and then essentially bind to it, which creates a blockage there. So the first drug we'll discuss is alemtuzumab, or Campath. This is an antibody against a cell marker called CD52, which is very highly expressed on malignant CD4 positive cells, which are typically the cell that is cancerous in mycosis fungoides. And this leads to a combination of reduction of those abnormal cells, or depletion of those malignant lymphocytes, and then activation of another group of cells called regulatory T cells that can be helpful. So the studies that I'll talk about today looked at patients with Sézary syndrome. So these people had blood disease, not a lot of disease on the skin, and excellent overall response rates were achieved, 86 to 100%. This drug is dosed through an injection into the muscle, so it's not given IV, and it's given Monday, Wednesday, Friday in the doctor's office. Here's an example of a great paper that shows in the first 3 panels how well this can work in patients who have true Sézary syndrome, which means that they've got blood disease. It shows up on the skin as redness and flaking and thickness of the hands and feet, but the problem is mainly in the blood. Campath has excellent activity in the blood, so this particular patient cleared beautifully. I want to contrast that with patients who have skin-based disease, where the disease is in that skin compartment rather than the blood compartment. Campath doesn't appear to have great access to the skin compartment. So in this patient example here, you can see that there was not much improvement there. This is a paper from Drs. Clark and Kupper that just kind of showed this red peak here. This is the abnormal clone, or the cancer clone in the blood before Campath, and this is it after Campath. So you can see that it was very effective in targeting and reducing that malignant clone. The next drug is brentuximab. This is an antibody against, or an antibody drug conjugate rather, against CD30. So CD30 is another protein that can be expressed in a few different disease processes. For our purposes, mycosis fungoides with CD30 positive features is the main category that we use brentuximab for. This is given as an infusion every 3 weeks overall response rates are reported at about 68% for mycosis fungoides and Sézary syndrome patients. The main problem with this particular drug is that it causes something called sensory neuropathy, which is kind of a pins and needles feeling in the hands and feet. It appears to be somewhat dose dependent. So patients who get many infusions of this drug tend to have more problems with this than those who only have a couple infusions, although it can occur at any time. And while in some cases it is reversible, in other unfortunate cases it is permanent. So that's a big problem, and definitely something that has to be taken into consideration when we're counseling patients about potentially using brentuximab in their treatment. That said, it can be incredibly effective. Here is an example of a patient who had pretty widespread plaques and tumors, and an excellent response to brentuximab, and this is CD30 positive large cell transformed disease as well. And here's a patient of ours who had big, thick plaques and tumors all over the legs, who was treated with brentuximab. He required a dose reduction because of some early symptoms of sensory neuropathy, and he had tremendous clearance. All of this was just sort of staining of the skin after the lesions had cleared, and all of that spontaneously resolved. He did quite well. A newer drug to achieve approval for the treatment of cutaneous T-cell lymphoma is called mogamulizumab. And this is an antibody that attacks a protein called CCR4, and you can see it here on the mycosis fungoides cell. And what that does is it leads to direct cell death, and then it also can be stimulatory to a bunch of positive immune responses that can also help to clear the abnormal clone. In the main study evaluating the efficacy of this drug, an overall response rate of about 28% was observed. The key point with mogamulizumab is that it tends to create problems for patients who rapidly underwent a stem cell transplant. So if we're thinking that a stem cell transplant is in your future, mogamulizumab has to be timed very carefully. You need to have a washout period before you can go to stem cell transplant. Immunotherapy. This is a newer indication or a newer use of drugs for cutaneous T-cell lymphoma. And we'll start with sort of a procedure that falls into this category called extracorporeal photopheresis, or ECP. So this is definitely a form of immunotherapy. And basically what we do is we take, you can see in step 1 here, we place a large bore IV or use a Metaport, and we take the blood out. We rapidly return the red blood cells, but we separate out the what we call the buffy coat, which contains all the white blood cells or all the lymphocytes. And then we mix those abnormal lymphocytes or the white buffy coat with the same medication that you take if you're doing PUVA. And that causes the abnormal lymphocytes to kind of break open, which exposes their antigen, which allows your healthy immune cells to better recognize that there's an abnormal malignant cell present. And then we infuse all of that fluid back into your body, which basically just enhances your own immune response to the abnormal T lymphocytes. So the abnormal T lymphocytes may be able to evade your native immune identification and attack before ECP, but what ECP aims to do is to kind of break open those abnormal lymphocytes to more readily expose them to surveillance from your healthy immune cells so that you can launch a more effective anti-cancer attack. So this is a patient undergoing ECP. It's given in 2 consecutive treatments, meaning say Monday, Tuesday, every 2 weeks or every 4 weeks. Each session takes about 4 to 5 hours, so it's a pretty lengthy process. The overall response rate in Sézary patients can be as high as 60%. One challenge is what we call access, or meaning just getting a solid IV that's going to last for 4 or 5 hours, or the need to place a Metaport or a line. So those are other things that you got to take into account when you're making a decision about starting ECP. It's often used in combination with other drugs, specifically interferon or maybe some skin-directed therapies, to enhance the overall efficacy. Transitioning to interferon, these are circulating chemicals that occur naturally, and they're immune response modifiers. They kind of enhance your antiviral or anti-tumor immune function. And then we can give them exogenously to try to manipulate that whole balance between self-tolerance and attack of cancer cells. It's administered for at least 3 months. And then in patients who are responding, you want to slowly try and taper that off as long as they don't flare up as you start to reduce the dose. Interferon alone, or as monotherapy, has shown to be beneficial across all stages of disease, with overall response rates ranging widely, but from 29 to 80%. Patients give this to themselves at home as an injection on Monday, Wednesday, Friday. And the side effects initially, when you first start using it, are kind of flu-like symptoms. So patients can have a low-grade fever, feel tired, maybe have some sore muscles. That typically resolves after the first couple doses. But then over time, you can have some reduction in your blood count or elevation in your liver enzymes. So monitoring is required. And as I mentioned earlier, with many of these other drugs, we often incorporate interferons in a combination regimen. So they can be given together with oral retinoids used with PUVA, ECP, or even PD-1 inhibitors. Transitioning to PD-1 inhibitors. So this is a group of drugs called immune checkpoint inhibitors. And basically what they do is try to prevent your tumor cell from turning off your attacking healthy immune T cell. So if you look over here, you can see that this is a cancer cell, and it's sticking out something called a PD-1 ligand. And when that PD-1 ligand binds with your healthy T cell, it shuts your T cell off. So we want your T cell to be able to bind here, recognize that this is a cancer cell, and attack. So what we do is we use these antibodies that prevent the cancer cell from being able to turn off your T cell. And so you effectively disinhibit your healthy T cell, which should result in effective destruction of the malignant T cell. So there's a little bit of trouble in using this drug theoretically in patients who have a T cell malignancy, because of the fact that we can't reliably expect that a malignant T cell is going to be targeted or even recruited in the same way that a healthy T cell will. And there's been some evidence from O'Malley's group that the malignant T cells kind of themselves can get disinhibited, which can lead to a worsening of disease. So we have to proceed with caution and just be aware of the mechanism of action and the fact that we're dealing with a T cell-based malignancy, which makes things more complicated. Nonetheless, pembrolizumab, which is a PD-1 inhibitor drug, is listed in the NCCN guidelines for Sézary syndrome or erythrodermic CTCL, not as a preferred regimen, but as an other recommended regimen. So it definitely has its role. And what we've discovered is that pembro or PD-1 inhibitors are especially effective at targeting that blood compartment, but not as effective in targeting the skin compartment. So in patients who are truly erythrodermic or have Sézary, this may be a good option if you've failed other prior therapies. However, in patients who present with primarily skin-based disease, it may not be the best choice. Nivolumab is kind of in the same category. There have been limited studies looking at this drug, but one reported an overall response rate of 40% in peripheral T-cell lymphoma and 15% in mycosis fungoides, ineffective in Sézary in that small study. There are a multitude of trials ongoing currently evaluating more closely how well these immune checkpoint inhibitors can work in CTCL. All of these are available on clinicaltrials.gov. Stem cell transplant. So this is the only potentially curative therapy. All of the other systemic therapies that we've discussed previously aim to achieve remission, but are not curative. So allogeneic stem cell transplant can offer you that potential long-term disease control. The interesting phenomenon here is that many people consider stem cell transplant kind of a last-ditch effort or something that you go to if you've failed multiple other therapies. But in fact, you have to have very tight disease control prior to stem cell transplant. And the reason for that is what we're essentially doing here is wiping out a patient's own immune system that they were born with, and then replacing it with somebody else's immune system that hopefully will not have that same fragility towards CTCL, and in hopes that they can better identify these abnormal cells if they begin to repopulate, and then in a healthy immune functional way destroy them before they're able to grow into a big burden of disease or create a big clone. Dr. Duvik evaluated 47 CTCL patients who underwent stem cell transplant during a 12-year period. And what she found was that the incidence of disease progression or relapse after the transplant was about 50%. Progression-free survival at the 4-year point was 26%. And then among the Sézary patients, the progression-free survival was 73% at the 4-year point. Of the 22 patients who relapsed or had progression of disease, they were further treated. And they were treated with either withdrawing their stem cell transplant related immunosuppression, or they were treated with skin-directed therapies, ECP, or chemotherapy. A couple of them received infusions of their donor lymphocytes, and 8 of those 22 achieved a second complete response. So although the post-stem cell transplant relapse rates are pretty high, 50% in this study, many of those patients are able to respond to further therapeutic interventions and achieve good durable remissions. The last form of therapy that I'll discuss today is called CAR T-cell therapy. So this refers to chimeric antigen receptor T-cells, which are T-cells that have been genetically engineered to produce an artificial T-cell receptor for use in immunotherapy. These have been shown to be incredibly successful in treating B-cell hematologic malignancies, but there are, kind of similar to using immune checkpoint inhibitors, some innate challenges when we try to apply this type of therapy to a T-cell malignancy. So just to recap, basically what you're doing is you're taking someone's normal T cells and then you're kind of genetically sticking in a fragment of their tumor cell to try to enhance the whole process of identifying tumors and then attacking tumors. So what can happen if you're targeting a T-cell problem with a T-cell therapy is that you can accidentally have something called T-cell aplasia, which means that all of your normal T-cells get killed. Or you can have a phenomenon where your nice engineered T-cell accidentally targets and kills off all your other engineered T-cells. So you get kind of a net neutral. Or you can have product contamination where you've got tumor antigens that are working their way into the clone that you're trying to create. So these are major challenges that we encounter, again, when we try to apply a manipulation of the T cells as a therapy to a T cell based malignancy. So research is ongoing to try to develop mechanisms to overcome these challenges and potentially allow CAR T cell therapy to become something that we can use in CTCL. Okay, so in summary, cutaneous T cell lymphoma is a very rare disease and one that remains poorly understood by a lot of oncologists and dermatologists. It's very important that you're able to find expert care so that you can get the most advanced and well-fitted therapy for you. I strongly encourage all of you to utilize the amazing cutaneous lymphoma resources that are available to you to try to identify a multidisciplinary cutaneous T-cell lymphoma clinic in your area. As we talked about today, many of the therapies are equivocal and their overall response rates are frankly underwhelming, in the 30% range. So the decision to pursue one therapy over another is very complex and very nuanced. It's important that you have a candid conversation with your provider in which all of your questions are answered so that you can understand why your specific treatment plan has been formulated the way that it has. I also want to encourage people to seek opportunities to self-educate. Again, the CLF provides many wonderful opportunities like this for education. Act as a self-advocate and try to make sure that the team that you ultimately form a relationship with to get your therapy is one where you feel that your questions can be answered and where you feel very comfortable making sure that yourself and your family are up to speed on why your treatment has been established the way that it has. So thank you.
Thank you so much, Dr. DeSimone. We're really appreciative of your time and your expertise, and thank you so much for explaining everything so well. I especially found your diagrams to be really helpful. So it's nice to sort of visualize things to understand them better. So thank you so much for being here with us today.
My
Before
pleasure.
we go, I would like to thank our corporate partners and individual donors for your continued support in making our programs possible. So thank you so much. And thank you all for joining us for this session. We really hope that you found it informative. And Dr. DeSimone will also be answering questions during our live Q&A panel. So please bring any questions that you may have to the panel for her. And please make sure to check out the other available sessions in the 2-day curriculum. And if you'd like to go back and reference this particular session, it'll be available on demand on our website following the event. Thank you very much.
Thank you.